So, welcome back. Um, if you are watching this video right after the first one, I had just said I was going to make this all into one video, and then Zoom decided to glitch and scare me and tell me that the meeting is being recorded after I'd been recording for like 45 minutes. So I, not going to say I panicked, but I panicked a little, and ended up stopping, thinking that maybe there was a problem and I never really recorded the first lecture. But I did. So disregard my words at the end of the last one that said I was going to do it in one shot, and now it's being done in two. But the nice thing is, for me and for, I guess, you guys, is that I don't have to record that first part again, because that would suck. So, hi, I'm back. In this portion it's a much shorter portion than the beginning, than quasi-experiments. We talk about small n experiments. Again, when we've been talking about causal claims in experiments, one of the big things, especially for statistical validity, that we've talked about is using more subjects, more power, detecting larger effects. But in the real world, once again, just like with quasi-experimental designs, small n experiments are necessary. Sometimes we have people with rare cases of things and, a rare disorder, and we want to study that person. So we do things like case studies, and we want to see if a treatment is specific for one person or maybe only a couple of people. And so it's still valid to see if this is effective for one or maybe a couple of people. Do we use the same statistics and group means and all of that together? No. Let's show you some of the differences. So in a large N design, remember that our participants are grouped and their data is grouped. So we don't look at data from individual participants. We don't care about individual data. We may have outliers. We may have other things, right? So we look at the group as a whole. That's why we've been using means, marginal means, cell means. We're looking at group averages. So in large N designs, the data from individual participants are really not of interest to us. We are looking at all the data from the participants in each group combined, either group to group in a independent or between subjects design, or comparing people basically to themselves, comparing everybody to themselves in a within subjects design, or within groups. So data in a large N design are always going to be presented or represented as group averages. The mean is strong in this one. For a small N design, most of the time, even if we have more than one participant, instead of pooling their data, each participant is basically treated as their own experiment, because what may work for one person may not work for another. In this case, small N designs are almost always some form of repeated measures or within subject, because you only have one subject. So you're comparing them to themselves, basically. Did this treatment work? Yes. Did this treatment not work? Right? We're not really even looking to compare person A to person B necessarily. So small N designs are almost always repeated measures in which researchers observe how a person or an animal, depending, responds to several systematically designed conditions. In this case, we are looking at individual data. And we know with generalization that what works for one may not work for everybody, right? So we're looking to see if they're responding to treatment themselves. So we treat each individual person as their own experiment. So, can it be true? Can you actually make a causal statement from a study with one person? Well, I would venture to say yes, because a person may have a problem. You see if there's a treatment. If with that treatment the person gets better or improves performance, then it's pretty easy to say you can make a causal statement that it was that thing. And there are different ways that studies are designed to see if we can actually do this. So let's look at some of these studies. And let's look at some of the people that we would want to see with a small n study. What type of disorder, what type of thing would we be able to use as an example? So we're going to look at research on split brain patients. As you guys are aware, even if you didn't take Psych 2, We have a left brain and a right brain, or left hemisphere and right hemisphere, and they work together. The corpus callosum from Psych 1, if you remember, brings the two together so that we can coordinate things on both the left and right side. But sometimes that corpus callosum has to be cut for purposes of saving their life. What about behavior changes, looking at clinical studies and other examples of small n studies? And then finally, we will evaluate our 4 validities in small n designs and see if they are the same. Obviously, statistics are going to be a little bit different than group data, but we would still look for statistical validity because we want to know that things work. So let's look at these things. So split brain patients are patients that basically split the left and right hemispheres into their own entities by getting rid of that white matter pathway that connects them and coordinates, which is called corpus callosum. Why, first of all, would somebody get a procedure where they would remove the corpus callosum? Well, back in the 1950s, we had a patient named HM who had really, really severe seizures. And what they did for him was they didn't really know what was causing them. So they removed some of these parts of the brain inside the middle of the temporal lobe, or just inside the temporal lobe, which turned out to be the hippocampus and the memory areas. So HM didn't really have seizures, but he also couldn't make any new memories. So in more recent times, with more technology, one of the things that people who were having life-threatening severe seizures was to cut that pathway that connects the left and right hemisphere. So patients that are called split brain patients, they're called split brain because they split the hemispheres into their own entities by getting rid of the corpus callosum, which shares information between them. So it prevents the two hemispheres from directly communicating. For those of you that may not know, that language is on the left hemisphere, and sort of literal exact meanings. On the right hemisphere is more of sort of the creative side and understanding the hidden meaning of like sarcasm or reading between the lines to get a joke, and things like that. So what they could do with research is put something in the left visual field, which normally goes to the right brain. So putting a saw in the left visual field, and in the right visual field, which usually used to go to the left brain, they would put a hammer, right? As you can see, in the right visual field, the hammer would normally be in the left visual cortex if it's allowed to cross over. The left visual field would be interpreted or picked up in the right visual cortex. So using this, you can put the saw and the hammer in their visual fields and see which one they come up with, right? So when we see this, what we're doing is not very many people, first of all, have severe enough seizures to get this procedure. It's sort of like a last-ditch effort for relief. You don't want to perform this on people unless it's absolutely necessary, because it's not the best thing in the world. It is interesting, though, and it can tell us a lot more about what the specific hemispheres do independently. So when we look at priorities in split brain experiments, we still want controls. Obviously, we would have some sort of, if you're comparing it to a normal person, because you have to have a control group to see what the normal function is, you would have somebody that's matched. Manipulation is still important. And of course, replication. But with replication, what we see in one split brain patient, do we see that in other split brain patients? Again, we're not trying to generalize to other split brain patients. We're just looking to compare individual cases to normal functioning human beings, right? And of course, studying special cases. Then what are some of the disadvantages of small n studies? Obviously, one of them is you can't generalize to other people. Each case is basically a separate entity. But let's talk about this. And what types of designs do we have for small n designs? Well, here we can look at behavior change in clinical studies by using what we call a stable baseline design. So in this case, what we want to see is patients with Alzheimer's disease for this study, and looking at a simple recall experiment. Here we see the percentage of words recalled. So as we know, most likely people with Alzheimer's disease have a lot of problems where their learning and memory function goes way down because those neurons that are responsible for it and some of the neurotransmitters responsible for it are destroyed. What we see is, and I used to teach, I used to give these cognitive type tests to Alzheimer's patients, so I know firsthand what it looks like. You give them a few words to remember, and then a minute or two later, you ask them how many of those words from that list they remember, and they're not going to be very, good at remembering these words. So you can see over a baseline of maybe 2 weeks or 3 weeks, we get a stable baseline of what their abilities are. And then maybe we can implement a new procedure. So in this case, there's something called an expanded rehearsal. So this was a type of clinical study. With this expanded rehearsal, they were able to recall a lot more words. In 2 weeks after the expanded rehearsal, you can see that some of them were at 80 to 100%. So here, just looking at the baseline versus the treatment, you can see that there was a huge spike in their ability to recall words. And again, this would be on a singular basis, case by case, subject by subject. So that's called a stable baseline design. In multiple baseline designs, what we can do is look at corrections of different things. So in this case, this was I believe this was a little girl on the autism spectrum who had problems with tactile function. So she would touch her hair, she would touch her face, and grabbing objects from other people. And in this case, we wanted to do, or they wanted to do in a clinical setting, a behavior change study. And instead of trying to get this little girl to, stop everything at once, they thought, let's do this method called an overcorrection, and let's see if it can work. But we're going to do it one at a time instead of trying to correct everything at once, because that might be a mess. So the first one is touching the face. You can see that there is a baseline for all three of them, where the number of times she touches her face gets higher and higher. Touching hair kind of goes up and down. Grabbing objects kind of stays pretty high. So you see these multiple steps that are taken. In the top phase, the first thing they did was an overcorrection for touching the face. So at the first dotted line, you can see that the overcorrection worked because the little girl stopped basically touching her face at all. Maybe once, there's a little blip that maybe she did it 1 or 2 times after, but it seemed to correct that behavior. But if you look straight down from that first graph, you still see that touching hair and grabbing objects was a problem at this point, because they were only correcting for touching the face. At the next dotted line in the middle, we see that the overcorrection stopped her touching hair, and touching face was already gone. Now touching hair at the second time point, the second dotted line, also seemed to have virtually disappeared based on this overcorrection procedure. But what you still see there is grabbing objects. Now there is a huge decline at first in grabbing objects. At the same time, it looks like that the hair is being corrected, but that pops right back up, right? So you see a huge dip in, just like at the first baseline, you see a dip in touching the hair, you see a little bit of a dip in grabbing objects, but those two things come back up. By the second step, you see that touching hair is gone, touching face is still gone, grabbing objects takes that huge dip, but then comes back up until the third overcorrection for specifically grabbing objects. And then by the end of the third step, you see that basically all of these 3 problem behaviors, touching face, touching her hair, grabbing objects, have all subsided. So we are looking at multiple baselines over multiple times to correct multiple things. And this is another way that we do this. Of course, we see this as a repeated measures design, right, for the one person. Of course, it's going to be repeated measures because you don't have multiple people per group. You only have one person. So you're comparing that one person's behaviors to that one person. So these are all going to be considered repeated measures designs. Finally, we have reversal designs, which may not be the most ethical, but it does help to tell you if there's cause, right? So we want to know that a treatment works. And of course, we only have one person. So here, we're looking to establish a baseline as we have in the other studies, right? Then we give a treatment, and then we want to know, right? One of the things that we talk about is confounds. So we want to know if the treatment actually worked, or maybe it was something else. So one way that we can detect that if we only have one person is let's remove the treatment and see if they regress back to their original or towards their original numbers, and then bring the treatment back and see if it works again. Again, this may not be the most ethical of things to do because you don't want to give somebody medication and then take it away and then give it back again just to see if it was the medication that worked. But maybe in a behavioral thing, like a cognitive behavioral training or something like that, maybe if you really want to know that this treatment works, then you can do something like this. But again, don't try this at home unless you're sure. So here we see at baseline, we see a green line, which is coping behavior, and we see a yellow line, which is depressive behavior. So for a person who is very depressed and not able to cope with the real world, and I'm sure we can all identify with this in some respect right now, at baseline, they have a lot of trouble, very low in coping, very high in depressive behavior. And then all of a sudden at that first line, we introduce a treatment, and boom, the green line goes way up. Coping behavior goes up. This is a support system with therapy, and at home, the family is really involved in making sure the person is attended to, taken care of, and really shown that this person is not alone. So depressive behavior at treatment goes way down. Treatment combined with family extra attention and things like that. So coping behavior goes way up, depressive behavior goes way down, and we see a reverse trend. Okay, it looks like the treatment works, but what if something else was going on? What if this person was taking antidepressants? What if they started exercising? What if there were other confounds or other things that could have caused this change in behavior? We want to know it was the treatment and the family attention and not something else. So we do a reversal. We take away the extra attention, we take away the treatment for a little while and see what happens. Here we see the depressive behavior start peaking again, and we see the coping behavior start dropping again, right, during the reversal. So yellow goes up in depressive behavior, the point of coping behavior goes down, and then we bring the treatment back again. When we bring the treatment back again, coping behavior goes back to way up, depressive behavior goes way down. So this is a way to show that this treatment was really effective. When we started the treatment after baseline, we see reverses in coping and depressive behavior. When we took that away and reversed it, the person reverted back towards the original high depressive behavior, low coping behavior. When the treatment was brought back in, boom, it reversed again pretty quickly. So this is a good way to show for this person that the treatment actually worked really well and that it seemed to be the treatment and not something else. When we took it away, the behavior trend reversed. When we brought it back, it went back up to acceptable, good levels. Again, it's not ethical in every setting, but for things like a clinical setting, when you're using some sort of behavioral therapy, you want to know it's the therapy that's working, then maybe this is a potential design, but we have to be careful. Other examples of small N studies, if you took Psych 41 lifespan, then you probably were able to, or if you had a Psych 1 professor, unlike myself, that was all about the developmental chapter, then you probably would have heard of Jean Piaget. Jean Piaget had a huge amount of literature and studies in child psychology, looking at learning curves, milestones, what children know and don't know at certain ages, and things like that. And many people don't really know this, but Piaget's subjects were small. It was small N studies. He used his own children, and he only had, I think, three children, I believe. So Piaget's studies, everything that he learned about child development was a small N study because he used his own children. In memory, if you took me for Psych 1, I talked about so maybe a word that sounds like it could be a real word, but it's not, like plabe, plabe, krong, sleer, something like that. And he would make a list of nonsense words and try to repeat them on one day. And then the next day, he would try to remember that list. And he wanted to figure out the curve of forgetting. So what he found in this case was the more times he practiced the list on day one, the faster it would take to relearn it the next day. So he called this the forgetting curve. And it's a great example of a small n study because his subject, as unbiased as he could be, was himself. So he was the only subject in this experiment. Maybe he was the only one he trusts. So the last thing we're going to talk about is evaluating the four validities. Internal validity in a small n design can still be really high. We're still looking to make sure that we don't have confounds, that we don't have history, maturation, attrition, all of those things. If the study is carefully designed, even though it's a small n study and you don't use the same statistics, you still want internal validity. You still want to know that you're getting causal claims, that it's causation, right? In that reversal treatment that we just looked at, let's introduce the treatment, let's take it away, let's introduce it again. That's a huge internal validity issue because it could be a confound. So you're still trying to mitigate and you're still trying to look for any potential internal validity flaws. I'm going to get back to external validity in a second. Construct validity, the way that you define your variables, the way you define your treatments, especially in a clinical setting, should also be really, really high because you still want the same operational definitions, you still want the same reliability and validity, you still want to be able to do that. You're just concentrating on one person instead of a group. So that should not make a difference. You're still trying to keep construct validity really high. Statistical validity is one that is not always relevant because small n studies are not using what we call inferential statistics. They're using individualized statistics. So the numbers that you get are not necessarily going to be the numbers that we deal with on a group level. So things like power and things like sample size which increase when you add more people to a group, we're not looking at statistics that way. So in this case, statistical validity, the way that we know it for group data, may not be the same. So it's kind of like, it's not always relevant sometimes. External validity, kind of the same way. The biggest problem with small n studies is external validity. Because each individual case is treated as a separate entity or a separate experiment, you can't really generalize. If we get a case study or we do an experiment on a split brain patient or an Alzheimer's patient, it doesn't mean that the Alzheimer's patient that we test next or the split brain patient that we test next is going to even have the same symptoms as the first one or is going to respond to the treatments in the same way. So with small n studies, it's really good to see individual plans for individual people, but you can't use it to generalize to others. So again, internal validity can still be really high. Construct validity should still be really high. Statistical validity, it depends. And external validity can really be problematic if you're trying to generalize in a small n study. So balancing priorities, which validities do we gain? Again, construct validity should still be really good. Internal validity, the way that we conduct it, should still be really high. The ones we sacrifice, external validity is pretty much a non-entity here. And statistical validity, it really depends because we're not looking at statistics in the same way for individual studies. Thank you guys for hanging out. And as always, I will talk to you soon.